Thank you very much for inviting me today. I don't think I've ever been introduced with a wolf whistle before, so here's hoping I keep you entertained anyway for the next 20 minutes, hopefully. And the main focus of certainly my presentation and some of the respiratory management has been touched upon with symptom management, etc. The main focus I'm going to look at is non-invasive ventilation and try and hopefully alleviate some fears about it and our expectations with it. So first of all, I want to look at two main respiratory muscles that you have, which Dr. Donaghy discussed. They expand the lungs and they contract the lungs to get the air in and to push the air out. So we've got the intercostals, which are like rubber bands in between your rib cage, and you've got a big main muscle, which is your diaphragm, which separates the rib cage from the abdomen. So here you have patient taking a breath in, so the rib cage comes out, the diaphragm goes down, it expands to help bring the air into the lungs, and equally then the diaphragm contracts, pushing the air out of the lungs. So when we breathe in, we're breathing oxygen. When we breathe out, we're breathing carbon dioxide. MND obviously causes the muscle involved in breathing to weaken. So it can occur gradually, but it can occur quite acutely as well. So it's to be aware of that fact. And occasionally, the first sign actually is the respiratory part of the disease, where we haven't yet, as you heard, sort of late diagnosis of patients by the time they're referred to neurology. The respiratory muscles, they may have thought it was a respiratory illness the patient might have had if it's smoking history, but actually it's muscle weakness that they have. So the breathing becomes more shallower than usual. There's less air drawn in, so oxygen's not getting in to the lungs, across the capillary membrane, used up by the organs, and equally the opposite, the carbon dioxide, the waste gas, isn't getting flushed out. So the patient is finding difficulty in breathing. It's more shallow. They're using work of breathing. They're using their shoulder muscles, their accessory muscles as we're called. And specifically when they are lying down, because the diaphragm is the only muscle at that time being utilised, then they could wake up being more short of breath. So that is another symptom to be aware of. So a person with MND mightn't even notice that the respiratory muscles weakened. Less than about 20% would be aware. There's a number of signs and symptoms that may help sort of emphasise this and bring it to the fore of people's mind. An early referral to a respiratory physician to help early diagnosis, maybe early intervention with NIV, cough assist techniques, secretion management, etc. So here's some of the presentations that may come to you, not just generally shortness of breath. Patient may have disturbed sleep, increased fatigue, quieter voice, you've already heard about vulvar involvement, excessive use of the accessory muscles if the respiratory rate's quite high, excessive secretions, which Catherine will talk about, panic attacks, waking up in the middle of the night, fighting for breath, weakened cough and sneeze, shallow or faster breathing, morning headaches, which would be a classic sign of your carbon dioxide retention, frontal headache, daytime sleepiness. Again, another classic sign of your carbon dioxide retention. So what we do at clinics and what your neurology team are very good at doing as well, maybe prior to they reach respiratory, would be spirometry. So we're measuring the breath out, the volume of air that can be exhaled out, performing arterial blood gas tests, which tell us what the oxygenation is in their artery and their carbon dioxide and their acid-base balance. Now, in a majority of MND patients, the acid-base balance can be normal, so it can be within 7.35 and 7.45 range. But the carbon dioxide part may be elevated. And even if the carbon dioxide is not elevated, but the patients are showing symptoms, they should be referred to us. So that is a major thing to actually get at the moment. Even if it's not like an acute NIV, these patients, if they're showing the signs of respiratory issues as you saw, they should be referred to a respiratory physician to get into the pipeline. You do sniff pressures, so the strength of the breath in through the nostril. Overnight oximetry, so we see if these patients are waking up during the night or do they have dips of oxygenation as they are sleeping at night. And if there's an increase in dips, then they should be considered for ventilation. So we do a baseline measurement, at their first visit. So these are the types of things that we would be doing here. So respiratory referral, urgent referral if the arterial carbon dioxide is equal or greater than 6 kilopascals. To be seen within 1 to 2 weeks, that's what we would be doing in the city hospital. If, as I've said, the patient's symptomatic despite normal CO2, saturations, etc., they should be referred for a sleep study. And again, if certain measurements here are less than they should be of the prediction, they should be considered to come to a respiratory clinic to be measured, to be seen whether they need NIV sooner rather than later. Because the sooner we get in with NIV, the better the quality of life should be. So management of respiratory symptoms may affect how other symptoms of MND can be managed, with the likelihood of rig insertion. Because again, if patients go for rig insertions, it has been found when they're supine, they get more short of breath because of the diaphragm issues. So do we initiate NIV before we're thinking of a rig insertion? Should that be something that we should consider? If we are considering the patient for a rig insertion, should we be thinking then at that time of NIV as well? I know it's a lot maybe to take on board, but it may prevent an acute issue rather than a sort of a build-up and more education and facilitation with the NIV. Something to consider. So the diagnosis and management of respiratory insufficiency is critical because most deaths are obviously from the respiratory failure. And there are nice guidelines, as Dr. Donaghy mentioned earlier on, have come out on NIV management in MND that came out revised guidelines in 2016. So the cause of death in majority of the cases is unfortunately respiratory failure. And the respiratory muscle function significantly predicts the survival and the quality of life for each patient. So it can prolong life and it can maintain a quality of life. So the evidence supports the use of NIV and helps address the symptoms of CO2 retention and most importantly the dyspnea that the patient is experiencing. So non-invasive ventilation, what is it? Well, it says, what it says on the tin. It is non-invasive, so you're applying a mask, whether it's over the patient's nose, full face, or total face mask, by providing ventilation to their lungs. So we're pushing air into the lungs to go into these small gas sacs called your alveoli. If you imagine it like a balloon, so we're increasing the size of the alveoli to get the oxygen in from the atmosphere, down into the lungs, into the capillary membrane, as I said, and equally bellowing out then, forcing out the carbon dioxide. We're helping avoid, at that, if we've got them just at that right period, tracheal intubation. It's mainly in type 2 respiratory failure that we're dealing with. So what we're dealing with are low oxygen levels in certain scenarios and high carbon dioxide levels. It can happen to patients acutely, where they've just got an acute infection maybe and they've come in quite unwell to hospital. It could be acute and chronic, where they've already had some maybe form of chest disease and they need it acutely. They've got an acute infection. Or chronic, which would be more to do with some of the MND patients that we would have. And what the machine does, it detects the person's breath in, gives them the breath in on inspiration, as it's called, and then as the patient breathes out, it forces a little bit of resistance in the lungs so that the airways don't collapse. Are you with me so far? How are we doing? Cool. Try to make it as easy as possible and not as technical as possible. So we can relieve fatigue in these patients. We can help with breathlessness, and we can also help with disturbed sleep. If you remember, they're waking up during the night. However, have in your mind, it's not going to help the progression of the disease. It's not going to help. The progression will happen, the muscle weakness will happen. So NIV in time, in certain scenarios, may be less effective. And we need to think about how do we manage those patients that it's now becoming less effective. Do we increase the pressures? The patient may also have increased time on the machine and become 24-hour dependent. If they're still 24-hour dependent and they're still symptomatic, that's when you guys, the palliative care team, are very important, working alongside us in respiratory and in neurology. That's where we are a big team and we try and work through these scenarios and each individual case together. It's very important. NIPI 3+ is the machine that we would deal mainly regionally. I am aware in the Southern Trust you use something different, but believe me, the styles of ventilation are the same, so bear with me while I just go through this with you. So there's 2 styles at NIPI 3+ that we deal with. First style is pressure support. Clues in the title, it supports the person's effort. So when they demand a breath, they get a breath from the machine. Pressure control, again, is like pressure support, but it's a timed element in it, so we can lengthen the period of time that they get the breath in, which may allow for more time to flush out the carbon dioxide. So they've got 2 levels of pressure. They get a big level of push of air on IPAP, it's called, which is your inspiratory positive airway pressure, and a lower level when they're breathing out, which is called your expiratory positive airway pressure. So the IPAP, patient takes a breath in, they get what we have set on the machine. And once the settings are made on the machine, can I assure you, nobody else has to touch it in the community, bar maybe under our prescription or Respicare under our guidance as well from a respiratory team. So once the settings are made, you should have to never, anybody that's out in the community, make any changes to the NIPI machine. What you're looking at is the patient in front of you, not the NIV as such. So we're increasing the tidal volume, it's called, getting the air in, and because we're doing that, we're helping flush out the carbon dioxide. On the EPAP phase, the expiratory phase, we're preventing airway collapse. We're keeping a little bit of residual in the airways to keep it patent, so that oxygenation can also occur. In pressure support, this is the easiest one probably to set up for a majority of patients. We set the IPAP and the EPAP for certain, it's called centimetres of water, because we're giving them above atmospheric pressure, which is 0 centimetres of water. It senses the breathing pattern of the patient. And the good thing about pressure support, if they rate should drop down, or if they should have apnea in certain scenarios, the machine will know, because we have programmed it to kick in. So it'll know to give a machine ventilated assisted breath for a certain period of time, and then that might just jumpstart the patient's breathing to come back into the same pattern. Pressure control, as I said, is the same as pressure support, but the inspiratory time we can set. We can make it longer, we can make it shorter. It takes a little bit more fiddling, but to get it just right for these groups of patients, because they would have hypoventilation, very shallow breaths, and sometimes some of them just need that extra period of time to get the carbon dioxide flushed out sufficiently. So this is a NIPI 3 here. Some of you know it, some of you maybe have never seen this before, but just to show you, this is a screen that you would see. So this is the inspiratory phase that the patient's getting, so it's been set at 12 centimetres of water. Expiratory phase is at 3. So the difference between these two, which is 9, is actually the pressure support they're getting in total. Inspiratory time is 1 second, so they're getting the IPAP at 1 second because we're under pressure control. So we're controlling just the length of time of the breath that they get. This is the backup, which is 15 breaths per minute. What that means is, if the patient should drop their rate below 15 breaths per minute, the machine will know to kick in. And if you ever notice the dial at the top here says 15, and this is 15, then the patient is not triggering the breath themselves. The machine's doing it for them at that time. The 2 things that we teach carers and the patient are the high flow and low flow alarms, because obviously this is a breathing apparatus, so we have to make sure it alarms if things like disconnection happens, if the patient takes a mask off in the middle of the night, or there should be a high flow leak, something's just come apart from the machine, that it will activate. And the low flow alarm is the opposite. So if a patient has a lot of secretions, it's filling up with bulbar issues, and the secretions they can't release, the low flow alarm may go off because it senses a blockage. Or if the patient does have a tracheostomy, it would sense that there's a blockage in the airway and need urgent suction. Or the low flow alarm could also go off because there are dust filters, etc. on the machine, and they need upgrade and maintenance of that by removing that and replacing them, because it senses there's a blockage somewhere in the system where we're trying to blow the air out to the patient. So on initiation, I like to go and just have a chat when the patient comes in. Don't take any machines to them. I go and have a general chat to find out what they have been told about NIV, what their expectations are, and to try and run through, have they any claustrophobia issues? What type of mask are we going to help, assist and make this comfortable for the patient, that they're going to be able to tolerate this. Let them feel what the push of air is, then bring the machine in, show them what we're talking about. And some of them are absolutely, you know, what they have in their mind of what a ventilator is probably something like the iron lung that we've had about 60 years ago sometimes in some scenarios. But another thing is Google is very good, because then I'm asked, you know, have you not got a smaller one? So that may come in time. I'm sure there'll be a ventilator you can maybe stick in your pocket in the future. You look at our iPhones from where we started years ago. So the settings are prescribed by the respiratory team, and we allow the patient time to acclimatise to it. Doesn't matter how long it takes, if a mask is off and on, it's very strange. And could I challenge each and every one of you today? There's a nippy outside, try it on, to know exactly what the experience is for our patients. I've had it on, and it's a very straight, you can imagine, no chest illness or weakness, etc., what it's like. I challenge you to try it on, to experience what it's like. The evidence out there would say about 6 to 8 hours sort of would be the minimum. And the reason we say that long period of time is because obviously you know yourself, if you've had a longer sleep at night, how good you feel and more refreshed the next day. However, there are patients who cannot tolerate this at night. So we try and work through, well, is there some periods during the day that you can add up to make it a good block of time? Every person's different. I have no hard and fast rules for all patients. I individualise my care with each and every patient, and everybody is different. All I can do is educate them that the longer they wear the machine, the better. But as I say, there may be blocks that it's required also. And as MND does progress, they may need to use the machine longer. They may need so many different types of masks if they get issues with pressure sores, etc. And also, I always take into consideration the patient's wishes. So with regards monitoring, we do have clinics, ventilation clinics, which are run, physician run, and myself, I do nurse-led clinics, but I also provide home visits. Now, you can imagine the difficulty in that regionally. Well, I am the only one that's able to actually go out and do that. It would be lovely if we could tap into the respiratory teams. I hope in the future we will. Certainly they can provide one-off calls maybe alongside palliative care or district nurses, but unfortunately they wouldn't be able at the moment with resources to carry out regular visits, but I hope in the future that may come. We're looking at their oxygen levels, I'm looking at their symptom management, and it may come that each patient needs to have titration of pressures, whether that's up or down, or whether the patient has gone home and hasn't used the machine. I need to address that so I can go out, or if they're able to come to clinic, to assess compliance issues, which they don't know of till I get there, till I've done it once. Do they feel they've got the support of the machine? Do they feel it's synchronizing? Do I need to alter a few things like with timings or trigger sensitivity to make it a little bit easier for the person to get the breath? Do I see their work of breathing coming down, or is it actually going up? Do they seem comfortable? Is it check for leaks around the mask and check the pressures and alarms have been achieved? That's the technical bit. This is another important bit to successful NIV, to assist these patients to feel comfortable and palliate their symptoms at home, is a proper fit of a mask, the right mask. As I say, there's so many different masks out there. This one is becoming quite popular because you can imagine within time, if I use a full face mask or a nasal mask, nasal prongs are very good as well, but we can only tolerate low pressures on that. If I have to go higher with pressures, that type of mask may hurt the nasal passages. So a majority of MND patients may resort to the total face mask, which prevents any pressure sores on the nose. Because if you imagine, if I get a sore on the nose, I'll show you a picture shortly in a little minute of that, how difficult it will be to vent that person. Just by looking at this sizing gauge, do you think that's the right size for this patient? Hands up, yes. Oh, I like it. You've maybe all seen this before. No, it's not the right size. So sizing is very important in patients to get it right with the pressures and comfort. So this lady here would have a huge leak here. The mask might actually go into the mouth. The air might go into the eyes and cause conjunctivitis. Big leak alarms may go off, cause anxiety. And the pressures won't be delivered that she has been set. And if we get it wrong, you get this. Now, thankfully, this is something from about, I'd like to think, 20 odd years ago, but it can happen. As patients, as I say, get more and more dependent, some patients mightn't tolerate a total face mask. This is actually down to bone. So you can imagine this is probably caused by several factors. Now, first of all, I think this gentleman has had an NG tube in, so venting probably has been quite difficult because obviously the leak at the mask, and maybe straps were tightened because of that. The other thing could be in the wrong size, and also we could have put something very sticky on it, like Granuflex, etc. And when we remove the Granuflex, you can imagine there's not much underneath there, but boom. So I've had a few of those in my career, but with the development of newer masks, etc., hopefully that won't happen. Just interesting. Has anybody seen sores after with the masks? There's a couple of you. Okay. So we need a comprehensive care plan. We need a multidisciplinary care plan. We need a coordination of all of our services together. We need to talk to each other, which we do. Frequent reviews. Are the patient are they able to have respiratory function tests monitored if they haven't been known to respiratory yet, to keep an eye on things? Maybe less than 3 monthly, as Dr. Donaghy said, it can accelerate quite quickly in certain patients. Provision of carers, and I just want to touch on this, on one interesting patient in case that I do have, who was established on NIV, but unfortunately she can't have 7 nights cover. So she kindly has some help from Marie Curie, etc., but she only has the NIV because she has no power in her upper limbs, etc., and her family try and help as much as they can, but there are 2 nights that she can't wear NIV. And it has come to the fore that her breathing can get a bit more difficult as her disease progresses. So she has reverted that we've tried to say, sorry about that. You didn't say about iPhone, iWatches going off, sorry, turn that off. So you can understand the difficulty with resources out there for these groups of patients who don't have the carers or the team at home, the family network, as you can imagine, is very difficult to vent these patients who have already been established. We have 24/7 care with regards and technical support, mask issues. We also have cough assist devices, and again there are no resources for cough assists. This is a very difficult issue as well, which I hopefully will be addressed in the future when we're looking at tender agreements in the future. Regular training can happen anytime, either between myself or the Respiratory or the company that you deal with should provide regular training and updates and upskilling. I'm not going to touch on this because we're going to have an expert of Jonathan coming up about withdrawal of NIV. I'm very interested to hear. Palliative strategies. Again, we work hand in hand, I hope, with palliative care, where we try and manage the symptoms, as you've heard from Dr. Anderson earlier on, where we're trying to palliate the symptoms when we maybe have exhausted everything with regards to the non-invasive ventilation. One last thing at the bottom here, I hope you're all aware of, apart from the contact numbers, is an oxygen alert card. Anybody not seen or heard of an oxygen alert card? Okay. With regards, where did it go? Oh, it's not there, is it? Oxygen alert card. Every patient I feel who's been diagnosed with motor neuron disease should have an oxygen alert card. They don't have an issue with their lungs per se regarding they need oxygen, they need ventilation, they have a muscle weakness. So if a GP who's unfamiliar with this group of patients, or a paramedic, historically what they used to do, if they went out and checked their oxygen levels and they were lower, say, than 92, 90, they would want to give them high flow oxygen. which is dangerous to this group of patients because it might tip them into respiratory failure and they may arrest right in front of you. Even the smallest amount of oxygen can affect these patients. So each patient should have been given an oxygen alert card, whether it's from myself or from neurology from the outset, or a letter to say to be very cautious. Then we also write to their GP, and we also inform their the Northern Ireland Ambulance Service as well. So sorry to digress on that one. But I'm not going to talk terribly much about medication because Dr. Anderson did a great job there earlier on. But just to also be aware, obviously any of this type of medication that we're giving our patients, they're going to get more short of breath. We're sedating them. Antispasmodics, opiates, benzodiazepines. So it's trying to get a happy medium, and the secretion management as well. If they're having a lot of secretions and we're giving NIV, we run into a lot of problems there because there's risk of aspiration to a certain extent as well. Invasive ventilation, don't think it's been discussed because this is a very burdensome and a big impact on the family and patient alone, but it is asked from the outset. Neurology are very good at covering this, and you're going to hear a great talk on advanced care planning later on and regarding ceiling of treatment. Oxygen I've touched upon, and the risk of maybe CO2 retention. We're reducing the body's signal to breathe, then they may stop breathing. Home care, ready access to medical device and involvement of GP services, reviews and home visits, regular monitoring of their medical progress, etc. If they're able to attend clinic appointments, or we have a key worker, the MND nurse is very good at showing us and getting in contact for support if there's any issues that have been brought to light to them. Technical support I've touched upon. Replacements of disposables and hardware. A lot of the masks are hard wearing. It's usually the headgear that goes first. So if you see it getting really sort of broken down and not sticking, etc. on the patient, can contact myself or Respiratory or the team that's dealing with the machine. Regular maintenance, regular family and patient education, and regular retraining and education is very, very good and necessary for this to work. Part of the home care network with regards to technical support, there should be regular service of the machines, usually about 6 monthly, emergency contact line. Mains power failure, there should be an alarm that alerts you to that, and most of these machines and equipments now have internal batteries. Accidental disconnection from the machine, the high flow alarm or disconnection alarm should go off. Any mask headgear issues I've discussed there. And then the increased use of NIV, that is your sign that the patient is deteriorating. The more and more they need it, the more symptomatic they are. We need to palliate the symptoms as well as possibly look at the NIV. And the alarms obviously are very important because it's a breathing apparatus. Did you even have to hold up the 5-minute marker there? You see? That wolf whistle worked. I don't think we're having questions right now, or if you want to, or we're going to all sit at the end. But thank you very much. That is my part over. I'm going to hand over to Kathleen now.